everyone. It is my great pleasure to once more speak before you. Hopefully, it will be very scintillating, as, as has been said. Now, I'm looking at penetrating the impenetrable. Unfortunately, when I was preparing this, one of my patients works in the feeder, so he told me that you must advise men that they don't penetrate anywhere. So please take that, otherwise they'll come for your neck. But for the canals, this is a very important lecture that you must know. Okay, so this is a topic that gives dentists a lot of problems, and I thought it is wise that we discuss the cases because actually more than 40% of the references that I get are because of sclerosed canals. And one of the things that come in handy is the use of a microscope. So you can see I've already done part one. I did train with a microscope long ago, but now there are new developments in microscopy. So again, I've decided to again go back to class and, advance myself in the latest in dental microscopy. So you can see one of my latest qualification is a certificate in dental microscopy from an institute in India, so that I can be able to do my cases very, very successfully. That is apart from the University of Nairobi. You can see the building there. That is the Nairobi Endodontics and Implant Dental Center, where I practice when I'm not teaching. And those are the cases that we normally get. Dr. Dienya was trying to get a canal here. I can't penetrate. Can you please help me? So those are the cases that we actually get. And we are now doing the 5th edition of this book, a very important book, textbook of endodontics. I think soon I'll be able to pass the word of the 5th edition, and those who are interested can contact me for delivery. Those are my co-authors of the same book. We are also doing the 5th edition of this textbook of operative dentistry, one of the first books that I wrote. Again, in 2 months' time, it should be out, and I'll be able to share it with you people. Now, because I'm representing East and Central Africa in the World Endodontic Congress, they told me to invite you for this seminar that will take place in Sydney, Australia. So please, you can liaise with me so that if you are interested in attending it, then you can be able to, we can be able to go together. And also this one from India. I'm happy one of our professors from India, Hedige, is here, professor of periodontology. We'll be soon be having this Indian Endodontic Society conference in 2025 in a place called Goa. So again, if you are interested, you can still get a visa. They only take 5 days, and you can accompany me to the same place. I've been there before, as you can see, and I'm still going there. I was actually the first man to talk to the Indian Endodontic Society, the first black man. Now, this is very important. So we used to say that illiteracy is the inability to read and write, but that has changed. In the 21st century, those who will be illiterate are people who cannot learn and relearn. So please do your best, and that is why I'm happy with you that you have come in this conference so that you can be able to learn. And I learned a lot from this animal here. This is called tardigrade. It has survived all the revolutions because it was able to change. So you must always also change with the changing situations, and that is how the animal looks like. So let's look at canal calcification. This is also called the pulp canal obliteration, a very, very important phenomena in dentistry because of the headache that practitioners get when they get these cases. Nowadays, I've adopted a protocol. One of my patients, a very senior politician, not the one who has died, but somebody else, came to my clinic. And he gave me a very big challenge that he wants to see the file that I'm using in his canal being opened fresh. So it actually tickled my mind that even if you sterilize your instruments using whatever means, the patient will only appreciate when you open them fresh. So I use this because Sonk also challenged me that look at that fox. It has gone to a mouth like this, and you go to a restaurant and you want to use the same fox. Will you be happy? That fox has gone to several mouths worse than this, and you want to use it. So nowadays, I've decided that I use a file fresh from the box so that the patient can see that it is new. And that is what I do. Like this one is for MB2. People don't know there's a specific file for MB2. You can liaise with me. This is a very good file that is able to negotiate MB2 even when it is carved. So you can see it is fresh. So I use it only once and then I throw it away. So that is the new phenomena. These are the cases that we normally get. You can see the sclerosed canal on my right there. The dentist could not penetrate. They referred the case to me. This one, somebody gave it to me. It's not my case, but I got it from somewhere. The dentist had selectively done endos on the two, but left the bad one for reasons that you know, isn't it? The technicality involved. I appreciate this kind of dentist. You don't attempt what you cannot do. This is good. He left it for specialists, okay? Good. These are the pulp obliteration or calcification can be divided into two. We have one where the canal is totally obliterated, more illustrated like the one on the left, okay? You cannot even see any canal at all. Then we have one that is partially calcified, like in that case. You can see there's obliteration on the coronal part, but when you come to the apical part, you can see a bit of canal. So you can either have total canal obliteration or you can have part of the canal obliterated. Most of the time, it's actually the coronal, okay? Because that is the one that receives a lot of, say, caries and everything else. So those are the cases we get. And you can see on the case on the right, the coronal part is patent. If you look at the molar there, the distal root, the coronal part is patent, but the apical part is obliterated. On this one, the coronal part is obliterated, the apical part is open. So those are called partial pulp obliteration. Now, why are we concerned with pulp obliteration? I had somebody saying you can just seal them and leave them. No. Most of the time, the bacteria are very, very tiny. And what you may see on your eye or on the X-ray as obliterated can actually allow bacteria to pass through. So that is why it is very, very important that we are able to handle such canals. And you can see cases like this, very common. Children get trauma. Then after a short time, even adults, you get discolored tooth. And when you take an X-ray, you get total canal obliteration or calcification. So the problem is, two problems exist. One, how do you locate the canal? That is another problem because getting the canal is one of the main challenge that dentists have. And even after you have gotten the canal, how do you negotiate the same? So this is just a schematic diagram on how you can handle canal calcification. You can see that if there are no symptoms, discoloration is there, and patient is only concerned with aesthetics, then you can go ahead and do aesthetic whatever, either bleaching or indirect technique, and you are able to solve that problem. But the second bit is what I'm concerned with. If you have a patient with symptoms, then you must be able to do root canal. Okay, and if you can't do root canal successfully, of course, you can do surgery or intentional reimplantation. But today, I'll concentrate on the non-surgical aspects. Okay, so difficulty in locating the canal, that is the first thing that the dentist need to, and you can see like this case that was referred to me, he had actually located only one canal. He could not locate the other, okay? So the dentist took a very good picture of the pulp chamber and we could only see one canal. The other one, the dentist tried. He actually tried. Then he told me, Doctor, hey, I can't even penetrate. This is just impossible. And I like the honesty in such a dentist. Then he said, I'm just putting something on the pulp chamber and referring the case to you. And that is what he did. So these are some of the bars that can help you go deep into the pulp chamber. My favorite is the EndoGuide bar from Coltin. Very nice bars that can help you penetrate. They are very tiny. So you are able to preserve as much tooth as possible, even as you penetrate. But you can use Mansi bar or Muela bars, especially the round bars for children, very tiny and able to penetrate the pulp chamber. And this is the difficulty in negotiating that I'm talking about. You try to put a file, you can't progress. Okay? And then some people think you can use rotary to penetrate a calcified canal. Most of the time you cannot. Okay, it is difficult and you end up with instrument separation. So that is another problem that you can easily have when you try to force your penetration into the canal. Now, of course, it needs a lot of patience. So while you are trying to penetrate calcified canals, always learn the art of being patient. I remember when I got Commonwealth scholarship to go to university, first of all, I was invited to University of Leeds before I changed to Malaysia. One of the things is they called us for an interview at 8 a.m. I reached there at 7:30 actually, but they kept us waiting until around 1 p.m. So when we asked why, they were telling us they are testing our patience, which is a very important thing in endodontics. And they're testing your patience and seeing what you do when you are waiting. Some people made a lot of noise. Hey, we are wasting our time. They were just disqualified immediately, okay? So it's very, very important as an endodontist or endodontic practitioner that you learn to be patient when you're doing that. Okay, what are the diagnostic techniques that you can use? You can use the IOPA, that is the commonest, but CBCT is now the standard. If you have a sclerosed canal, please always employ the use of CBCT. And you can see, this is what I trained with, ICAT, a very good CBCT. And this is the kind of things that you get. Like I got this case, the dentist had actually did not identify MB2 canal. And you can see the MB2 canal on the last radiograph. It's there but sclerosed. So these are the kind of cases that I normally get. And we were able to solve the problem without an issue. You can also get a case like this, where you have total sclerosis. No canal can be seen at all. Okay, so dental operating microscope, that is why I've decided to train on it, is very, very important in managing sclerosed or calcified canals. And you can see that is the type that I'm using. I'm very grateful for SmartDent. They imported for me one, which I wanted. I gave the specifics. Then they imported for me one, exactly what I wanted. And I'm now very happy with the one that I'm using. And that is the one that I'm using, the latest one, the latest technology with artificial intelligence. So it is able to actually capture everything that you need. Now, you can also use staining techniques when you are trying to identify canals. And the one that I normally use is methylene blue. I have it in my office. So this is a very good dye. And you can see it has stained all the possible orifices. So you may ask, you cannot see the orifices, but this dye is very, very helpful. It is even telling me there is what we call C-shaped canal. The canal is actually running continuous. So this dye is very, very useful when you want to identify the canals. So you just follow where it has stained, and when you do the poking with ultrasonics, you are able to arrive at the next canal. You can also use ultrasonics. This is very important in management of calcified canals. And we have quite a number of suppliers with this. You travel around with ultrasonics, especially the Pro Ultra. I got some from India. Very, very nice in traveling around when you are doing sclerosed canals. And this is the motor that I use. Ultrasonics come with their own motor. This is very nice, VDW from Germany. I got it from Pharmacen. A very nice motor, and you can even change the speed depending on what you want to do. It has retreatment, cavity, removal of broken instruments, and so on. Then you have the Endodontic Explorer, especially DG16, very handy when you are looking for canals so that you can be able to identify the same. So thermal and electrical pulp testing is important. You must know whether the tooth you are treating is vital or not. So you must do an electrical pulp test, and that is what I normally use, so that you are able to tell the patient this tooth is still vital, and therefore you need to have the root canal done, although it is having signs of irreversible pulpitis. So it's very important to know the status of the pulp. Another important thing when you're identifying sclerosed canals is what is called the Champagne tests, okay? Open the pulp chamber, put conch 6% hypochlorite, and you will see them bubbling like this, where the canal is. So that is called Champagne tests, okay? So this is a very important way in which you can always, in which you can always identify the sclerosed canals. I've realized quite a number of dentists use JIC. Please, JIC as a surfactant, which may not be useful for the tooth. Actually, they can cause harm. So try to use dentally approved hypochlorite like the Clo Extra 6%. That is the one that I recommend. very, very good in dissolving inorganic tissues. Then look for evidence of sclerotic dentin. Like you can see these white patches. These are evidence of sclerotic dentin. And those are the ones that you're looking for when you're dealing with sclerosed canal. So whenever you see those white patches, most likely, like here, you can see here, most likely you have a canal. So that is a good guide on how you can locate the canals. Armamentarium, you must have a microscope. I realized recently I was in Thailand for some seminars, and then I went to Singapore. I realized that almost all the dentists who are practicing endo, quite a number of them, almost 50% have microscope. So please make sure you have a stiff file, you have a microscope, you have a lubrication. What we recommend in sclerosed canal is the continuous chelation technique, whereby you have a chelator like EDTA. In this case, we use etidronic acid. You mix it with sodium hypochlorite, so you are able to disinfect the canal even as you are removing the sclerosis or the sclerosed part. And of course, you must have a highly flexible rotary files, such as the rising. I like the rising from Fanta. This is the one I use first of all. C+ files are very good for sclerosed canal. So these are the ones that I recommend that you use. Fanta company has also this one here, the Fanta Finder, supplied locally. These canals are very, very nice file of choice for narrow and calcified canals. And these have really helped me a lot. And I like them coming in a single pack. You open it, you are able to actually manage the sclerosed canals without any stress. And these are the files that I use, single use. They are quite affordable, very flexible. Once you have identified the canal, you start with the orifice shaper, then you go to number 10, then you go to the next file, which is also very small. We call it the path file, okay? Then after that, you can complete your, you can complete your preparation. And I like them because each protocol, there's protocol for single canal or single technique. For moderate cases, for extreme cases at large canals, you also have a protocol. So it serves all purposes, and it is very affordable. I was surprised it's charged only at 3,000 per set. So I'm able to use it per patient, finish the procedure, and discard it away. Okay. This is very important also. This one I got, I think I got a version from Dr. Simi, which is important. As you work on a sclerosed canals, you can easily deviate and cause perforation. So it is important that you monitor with a digital X-ray. Of course, you must follow the protocols, otherwise you deviate. So very, very important that you monitor. So you must have a digital X-ray somewhere so that you don't have to move the patient with saliva, rubber dam, and so on to the next room. So this is very handy, especially when you are handling sclerosed canal. Mobile X-ray, very, very critical. This is what I mean by continuous chelation. I normally get supply from India, quite a lot. Etidronic acid, mix it with sodium hypochlorite so that as you remove the calcified tissue, you are disinfecting at the same time. Otherwise, if you remove the calcified tissue and some of them are bacteria, you can easily extrude, push them down. So that is why it is important that you mix sodium hypochlorite with etidronic acid in what we call continuous chelation technique. And this is very important. It is very, very critical that you activate the solution so that it can go into the lateral canals, dentinal tubules, and so on. So my favorite is Dentsply Endo Activator, so that you tickle the solution, what we call tsunami irrigation. Very, very critical, so that you reach all the areas of the root canal. So the procedure, once you've identified using those techniques, then you start with the number 6. You do poking in at a time, okay? And then you continuously irrigate using the continuous chelation technique. Then you change to number 8 and 10. And then after that, you can actually do rotary. So I use rising files. I like them a lot. And you can see what I'm doing there. Sorry, I'm told that it's not very clear from the other end. But you can see, you do the poke in like this. And then you do clockwise rotation, like somebody doing watch winding technique. So you can see I'm doing poking in and then winding, poking in and then winding as I penetrate the sclerosed canal. And there is me with my assistant. It's very well trained in microscopy. So we work together as a team, and you can see what we are doing there. Very, very important, especially in management of sclerosed canals. So sometimes it is impossible even when you do this. So we use also the static guides. This is the latest advance in management of sclerosed canals. And I'm very happy. I don't know whether he's here. Dr. Shalin Vinayak has been doing for me the planning and fabrication of the stent, especially in all cases. So like this case, somebody comes, discomfort from 1-1, you take an X-ray, sorry, part of it was cut off, but you can see it is completely sclerosed, okay? What do? I do a CBCT, then I send to Dr. Shalin Vinayak. He does very good planning for me, 100% correct. So I take a CBCT, then he fabricates for me a surgical stent like that. And then now, you see, I've drilled, actually, I'm able to drill. And you can see we are able to finish the case without any problem. So that is the use of static guide in management of sclerosed canals. You can also do it in molars, like this case. The dentist was very honest. I really like people like that. He told me, hey, I've finished the distal canal. But Dr. Dienya, I can't even penetrate the mesial at all. I can see it on my IOPA, but I can't penetrate it. Sijui ni shetani ama nini imenifanya. I said, Father, that's normal. So I also realized this case can be tricky because this is a very high profile patient, by the way. So I decided to do the static navigation, got the planning, and you can see we have penetrated the canal. I think the results is here, yeah. Okay, so very, very important. You can see we are using the high speed and we have already gotten the canal. This is there, and then that's the final bit. He also didn't do the, sorry, I'm gossiping, but he didn't do the distal canal well, so I had to redo it again. you see, it was a bit short, eh? Okay. But anyway, that is okay. Sometimes you have challenges. We can't blame colleagues. You have limitations of instrument challenges, and just you have so many patients to see. But as you see, we have to get it right as endodontists, so we were able to do that and finish. I visited Israel and went to the beach in Tel Aviv, but I realized I was overdressed for the occasion. I've also been to Manila where Dr. Seviu trained, and I was happy they put a beautiful lady as they welcome you to the country. Okay. And then recently I was in Thailand as a guest of the Thailand Dental Association. Again, I was the first Black man to speak to the Thailand Dental Association, and they were very happy. You can see I'm really black, isn't it? Okay. These are cases that I get from people. Sorry, sometimes I label them because I want to give a feedback to the referral. So if your name appears in any of the slides, not in a bad faith, but just for me to label and thank you for the referral. So this was referred to us, and we can see somebody was trying to access a canal. He ended up breaking an instrument because we advise people don't use rotary in a sclerosed canal. It will not penetrate. Use rotary only when you have created a glide path. You get that? So don't use rotary directly because you end up with a situation like this. We were able to remove it and we were able to complete the procedure without any problem. This was also referred to me from Kenyatta University, teaching and referral hospital. I get a lot of cases from there. Somebody was trying to do a lower premolar. He cleaned it, then he could not penetrate. I like that. He said, oh, doctor, I've done it. I put non-setting calcium hydroxide, but this canal can't just go. And I feel guilty that I should obturate it at this point. What is your opinion? So I took up the case. I realized, oh, it is a premolar, lower premolar actually with Bertucci type 5 canal, starting as 2 and ending up as, starting as 1 and ending up as 2. So you can see the way I did it and finished the case. My name is there on the slide. This is also another case that I got. Somebody told me, I've already penetrated the canal, but I can't do the apical 1/3. What do I do? I told him, please send over the case we see. He was able to send the case, and you can see we have done it and even got a puff at the end there. And the patient works in West Africa. She was able to do, we were able to do it in a single sitting, and I've been calling her, she tells me she's fine. This is also a good case. This is also from Fanta. I like their files very much. This is only 1,500, and it has 3 files. So for straight cases, you can just use these single ones and throw it. You don't have to sterilize it at all. And I think they'll be having it somewhere here in the seminar. Lower premolar, somebody referred to me this, lower premolar, okay? He had a broken instrument. He was trying to penetrate the canal with a rotary, and then he found that, oh, the file has broken. So he referred the case to me. I was able to remove the file and continue with the treatment. So I sent it back to the prosthodontist who will put a post and hopefully do a crown for that tooth. Same to this, I got this case from Aga Khan. The dentist took an X-ray and just said, hallelujah, this one I don't want to attempt. It is a third molar, it is badly inclined, it has a sclerosed canal. What do I do? I said, oh, let me send the case, I try. Sometimes also we fail as consultants, so you always say you try. Don't make a promise that you will finish it. You say you try. So he came and I was able to do it. I got Vatucci type 3 starting as 1, dividing into 2 and ending as 1. And the distal root was quite okay. The one that was sclerosed, we were able to finish. Even taking X-ray in this case was a big challenge, but I was able to do the final X-ray and send the case back to him. Even bought for me a watch, by the way. This guy was so impressed with my skill on that case that he sent me this watch, which I still have. This is Dr. Olu. Sorry, I normally label them because sometimes I want to thank the patient because of many cases I can forget. Not that I label them in a bad way to malign anybody, just the person who has referred. He also got this case walking to his clinic. So it is not his mistake. He got the case walking to his clinic. Then he said, "Hi, Dr. Dienya, this is enough problem. Somebody has broken a file. The canal is sclerosed. I can't attempt it. Can you be able to help?" I said, "Let me just send the case off. I can try." Then I was able to do it, and you can see we finished it very well. And I was able to send him a report of thank you for. The patient even gave us some bonus money, which I sent to him because I didn't want to take. Then Oira, this is my master student also, very good colleague. This patient walked into her clinic to seek a second opinion. Somebody had attempted root canal. You can see on the mesial root, some people can really search for a canal. Please don't do this. When you see it is not coming, leave it, refer, okay? So when she came, I looked at it with a microscope, and this is what I got. The case is still ongoing. I just got it the other day. We'll also do end on the third one there. Don't worry. That will come later. Patient doesn't want to lose the tooth. This is Dr. Mohammed. I normally call it MOH. So he normally gives me a lot of cases again. When he gets a case like this from somebody, a lot of cohorts are also trying endo. So this case came from a cohort, walked into his clinic, then he brought it to me. But there was a lot of damage to the tooth. Although when I sent it to the prosthodontist to do a crown, I don't know what he put in the middle there, but I can see maybe a fiber post. So this is what I got from the prosthodontist, but we had done the endodontic bit. But to me, this tooth looks as if the prognosis is questionable. We'll look at it. We'll keep on monitoring the patient, possibly for implants. Then that is another case. Again from Aga Khan, intern in dental school, not Aga Khan, intern. So the intern took an X-ray, and this is what he found. He said, I can't even see the canal, and this is a third molar. So Dr. Dienya, I don't even want to attempt. This one I'm referring to you direct. So when the patient came just the other day, I was able to get on the distal root 1 canal, which is curving, and on the mesial root, surprisingly, I'm getting Vatucci type 7, starting as 1 canal, dividing into 2, meeting as 1, and then dividing into 2. So I do agree with the intern that this was very complex and he may not have been able to, negotiate it at all. Sorry, I'm just finishing. This is another case that I got. Broken instrument, perforation, and so on. I was able to, I think I posted it on the dentist site. I was able to negotiate the canal and finish it up very well, and the patient is recapitulating well. But what I would advise is surgery cannot solve a problem of sclerosed canal. Somebody had done surgery and even did root end filling, but still the tooth was symptomatic, a lot of bone loss around the tooth, and now I'll call the patient and check whether the healing has occurred. So thanks a million to all the dentists. It is because of you that I'm eating, and I'm very, very happy. I'm very, very happy for that. Yes, I still have one more lecture to go, but I don't know whether I can take questions on this so that we don't combine them.
I think, Dr. Dienya, because we have 10 minutes to go, maybe you do the other lecture, then we just take all the questions together, if that's agreeable by you. Or we take one or two questions.
You can
then
take
you
questions on this, then
Yeah.
we progress.
Yes, let's just take anybody who has a question. I'll bring the mic. Reno will bring the microphone to you.
Anybody with questions on calcified canals?
There is a hand here, Dr. Reno. Right, there is a microphone there already. You can proceed.
Yes, thank you, Dr. for the presentation. My name is Dr. Omar Elias. My question is about irrigation. Dr. You have emphasized about issue of sodium hypochlorite and EDA, the chelating agent. And the research is more focusing on the combination of two material whereby the EDTA is being deactivated and the chlorine
Not EDTA, not EDTA, is etidronic acid.
Okay, so kindly can you just enlighten that one again so that maybe I misunderstood the presentation, that part?
Oh yeah, don't combine EDTA with sodium hypochlorite. That is undesirable. It will actually reduce the efficacy of EDTA. What you combine is a chelating agent called etidronic acid together with sodium hypochlorite so that you have what is called continuous chelation. That means as you chelate with the etidronic acid, sodium hypochlorite will disinfect the area. So that is why we call it continuous chelation. But EDTA, if you have to use EDTA, then use EDTA. Then after that, use normal saline to remove the EDTA and then use hypochlorite, okay? Don't combine direct EDTA with hypochlorite. Don't. Okay, I hope that is clear.
Very clear, thank you.
Okay.
All right. Thank you, Dr. I think now we do the next lecture in 10 minutes, then we take a question. Please.
Yeah, let me do the next lecture. I think we are approaching lunch hour.
Yeah.
I'm sorry they gave me a very little time for the next lecture, which is equally scintillating, but I'll go by the rules of the...
Thank you, Dr.
Yes, can you project it, please?
Thank you for your graciousness. Just 10 minutes, we take questions. And as that is happening, there are two hands-on courses coming on in the afternoon. There is the Clear Smile by Dr. Mzamil Sadak, and there is also the anatomically directed endodontics by Dr. Simiyu.
Please, can you set the next lecture?
A bit of slots in both of them too, so you can always contact KDA to register. The next lecture, please.
Sorry, they're having a technical issue, but I hope they'll sort it out in the next lecture. So I'll just rush through the next lecture. It would have been a very good one for discussion, but because of time, which we must obey, let me just allow me to go through it very quickly. It's not moving. What did I do? It's here. The avulsion, this one. Avulsion. No, this one. This one. Something to go. Yeah, that's okay. Huh? Just yeah, my face, it is not a slideshow. From beginning. So my next lecture will be on management of tooth avulsion. I've actually done almost 30 cases, but because of time, I'll summarize only 3 cases because of the lack of time. Very, very important. Again, yes, this is, you can read this one here. It summarizes very well. It's one of the latest articles. So now to manage avulsion of permanent teeth. And that is normally what happens, especially in sports, violent sports like boxing, you get that loss of teeth. And of course, the maxillary central incisor is normally the main tooth that is involved. So what do we mean by avulsion? This is just complete and total displacement of the tooth from its socket, and it compromises about 0 to 5, 3% of traumatic injuries, and 7 to 13. So it is more common in children than in adults. So cases like those are very, very common. Some people also call it X articulation. And that is what you get, very common in children. Anderson suggests that the loose structured periodontal ligament may be the reason why the erupting teeth are the main victims of avulsion. So you end up with cases like this. This is just a classification. The one that I use most is from Ellis. So this is classified under class 5, which is total loss due to trauma. And that is what you get. So the main salient question that we need to ask, what is the concern? What is our main concern? Is it the pulp? Is it the socket? Or is it the PDL? And from the researches that have been done, it is the periodontal ligament cells that you need to preserve. Okay? Those are the most important. And you can see what is happening. The periodontal ligament space, as the tooth is removed, they get stretched and then they get broken. So that is the one that is of main concern. So the PDL tissues, including the fibers, are the most important factor to consider. So for you to succeed in returning the tooth to its socket, reimplantation, you must have a viable PDL. That is what I'm trying to get. If you don't get, you end up with that kind of resorption, external inflammatory resorption, or even ankylosis. So this is something KDA should be doing, educating parents, not just on caries, but also what happens when a child loses a tooth. This is an education that we need to carry out. Parents, caregivers, and teachers, you can tell them, once you lose a tooth, once the child loses a tooth, let them hold the tooth by the crown, not by the roots, okay? And 2, let them clean the tooth with rinsing normal water, or even tap water is okay. Then number 3, they can reimplant the tooth at the site where it has come out. They can actually put it back in the socket. And then number 4, if they're not able to put it back in the socket, then they can use a preservative like milk. And then time is very important. Number 5, time is critical in management of a avulsed tooth. So these are advices you can give on phone. And the main preservative that we have are milk, Hanker's balanced salt solution, saliva. You can even put it in the mouth, and also water, although water is generally a poor medium for this. So these are the types of storage media that are in the market. Because of time, I'll not go into the merits and the demerits of each, but the most important one that I use is the Hanks Balanced Salt Solution. Very, very good in regeneration of periodontal fibers. So that is the one that I prefer, and it comes in this container called Save a Tooth. So you put the tooth inside. Even if the tooth has been treated poorly, you can still put it inside. Milk is second. You can use milk to preserve. And also you can use saliva. Keep it on the buccal mucosa. You can tell the patient through education that they keep it on the buccal mucosa so that it maintains moisture. And also you can use the tap water. Water is the most undesirable because it is hypertonic and it will cause rapid cell death or lysis. So these are the guidelines for implanting avulsed permanent teeth. So there are 3 things that you consider. The most important thing to consider is the time when the tooth is outside the mouth. So that is very, very important. If the tooth has been planted prior to arrival, then that is very okay. If it has been maintained with storage time less than 60, that is still okay. But if it is dry, somebody has put it in an handkerchief, on a tissue, or on a paper, then you are in big problems. Okay, so the state of the PDL is the most important in as far as reimplantation is concerned, okay? So if it is less than 60 minutes, or if it has been reimplanted, that is fine. But if it is more than 60 minutes, know that you are heading towards ankylosis, and your focus should be, how do I prevent root resorption, okay? That should be the thing. So this is just a protocol. I'll give the lecture to KDA. You can share on how it is going to be used. Okay, and this is the protocol for management in closed apex. The other one was open apex. Closed apex, you can use this protocol there. And this is the treatment, okay? You do the case history, and then of course you actually replant the tooth. So time is very, very essential, very, very critical that you actually do. So these are the implantation steps. Because of time, again, I'll not concentrate on it. And those are the still steps continuing. If it is closed apex and the tooth has been reimplanted, very okay. You just take a radiograph, verify that the reimplantation was correctly done. If it is not well done, you can twist it a bit, and then you leave the tooth in place. Then after that, you will use a nylon fishing line, or you can use a titanium splint to actually splint the tooth in place, and you leave it for about 4 weeks. Then you can also do, after 2 weeks, you can do endo, okay? You initiate root canal within 2 weeks, give antibiotics, check tetanus status, and then give post-op instructions. Then if it has been stored, the same procedure, I'll not go through it. Now, the main concern is when it is not been stored, okay? When it is less than 60 minutes, that is still fine. Always hold the tooth with the crown like that. And I'll skip there. And then you implant the tooth. Then you ask the patient to bite on a handkerchief, and that is fine. But now, when the extraoral time is more than 60, now there you are in problems. The main aim now is to prevent root resorption, okay? So this is what I use in my clinic. I have ladder mix for intracanal dressing. I have Stroman Emdogain for surface treatment. And I also bought this one recently, which has been found to be very, very more applicable in regeneration of periodontium. It's called the growth factor. It's called the growth factor, which is the one in the beginning here. Previously, I've been using this, but I find this very, very useful. So we dress the canal with ladder mix, then apply any of this on the surface of the roots. And then in the second visit, you can do your root canal treatment. And then you remember, once it is more than 60 minutes, the prognosis is generally very poor, okay? Most of the time, you end up with this kind of thing, ankylosis. Okay, so stabilization, I use this one, titanium is the best. Titanium, it's called the titanium trauma splint, that one there. That is what you can use to stabilize the tooth. Or you can use fishing line, nylon. And then, of course, you give them antibiotics. So these are for you to get satisfactory outcome, the tooth should be asymptomatic, normal mobility, normal sound. If it is asymptomatic and you get high-pitched sound, you knock, you say, ta 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 ta, already you have ankylosis and the prognosis is poor. So very important how to identify the prognosis. Those are cases that I've been doing. This patient was actually having ortho when they came to me. And you can see the tooth was just kept in water. I returned it back. And that is how I'm myself working on it. And this is what I got immediately after returning back. Then 3 months later, it was still like this. So it is so good. It's doing well, okay? Despite the storage having been water, I can see he came 2 weeks ago, and the recent photo is showing I'm succeeding in this case. No problem. Then that is another case too. This one, the mother was a bit wise. He had stored the tooth in milk, okay? So when they came, I was doing the fixing there. You can see I'm doing the fixing there. The child is very cooperative. I liked her a lot. And the tooth has been fixed. So at that point, I just tell them to bite on a gauze. Yeah, and I can see that. Then I take an X-ray. And I could see that is. Now this patient also injured the alveolar bone. So that is why I put another splint there on top. And the recent photograph is. immediately. Remember, the concern is the periodontal. An associated alveolar structure, the first thing also is to stabilize the fragment, especially on the anterior maxilla or the premaxilla. So you use a splint. That is why I used a normal OMF oral splint that we use for that kind of case. But also you put a splint in the middle of the tooth. So you have two stabilization when you have associated alveolar fracture, so that there's no movement, because the movement of the bone fragment will interfere also with the healing of the tooth. So you must have a splint that actually stabilizes the bone and another splint that stabilizes the tooth. So it is a double splinting technique when you have an associated alveolar fracture. That's a good question. Thank you, Dr. Yes, my good student, former student.
Thank you very much, Dr. Dienya. Let's give a round of applause for Dr. Dienya.